Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. You'll also hear from Benj Brayman, our media and graphics design producer here at the Exam Room podcast. Benj brings over a decade of experience producing multimedia content in the healthcare space, including work with major organizations like the Core Institute and the University of Phoenix. From video production to motion graphics and audio storytelling, he's the creative mind behind how this podcast looks, sounds, and feels. And when he joins the conversation, he brings a unique perspective grounded in both design and real-world healthcare experience. How do you measure success in healthcare, and does it go beyond patient numbers? In this episode, Dr. Winsor is back in the exam room with Dr. Robert Babyar to explore how quality metrics, community partnerships, and strategic planning can transform a health center's impact. They talk about balancing clinical outcomes with patient experience and why defining success for your organization can inspire both staff and stakeholders. We thoroughly enjoyed this conversation, and we're sure you will too. Let's get into it.
So you've shared some really huge successes. I have a hard question. How can other health centers do what you're doing? What's some words of wisdom that you could share?
When it comes to doing what you're doing, I think that the vision needs to be there, and that vision needs to come to everybody. And how do we communicate that vision out of where we're going and what we're doing, right? There is always strategy. There are always pieces and elements to that. But when we're talking about what other health centers can do, I always say, what do you want to do? And if you know what you want to do and there's buy-in that others agree that is worthy of us doing, then find the people that know how to do it. When it came to the pharmacy, we had tried pharmacy services before I came to Adelante about 9 years ago. They had a pharmacy and were doing it. And we didn't have the knowledge or the expertise to do it well, and it failed. And we were reluctant. We didn't have a need for the pharmacy on site because we had other arrangements with the Walgreens and the Walmarts and the Fry's and the CVS's around our sites that allowed us to take advantage of the discount program, that 340B program. But changes to that program aren't allowing that anymore. So we recognized that if we're going to continue to serve our patients and provide for our community, we have to change. So we partnered with an outside organization that does this. This is what they do. So they have the knowledge and the expertise, and they're helping us side by side put it up and get it running, and not in formal way, but indirectly teaching us what are we doing, how are we doing it, how do we do this, so that eventually we can take it over and then they can go on to their next place to help, right? It's one of those things where if you build it, then keep it sustained, and how do we keep it sustained? So that has been a piece. But you've got to know what you want, and you have to be able to focus your wants, because there are 1,000 different things we could be doing for our communities and for our patients. Whenever we analyze what we want to do for our patients, there's three factors that kind of drive that idea. From the clinical side, from the clinical operational side, these are the things that matter to us. The first is health outcomes. Is what we're doing going to improve the health outcomes for our patients? The second is, are they going to be happy with it? And not just the patients, but the staff and the providers. The satisfaction in the work they're doing has to be there. We can't do something that's great for patients that is such a burden on our staff that they resent doing it, right? Or that they don't feel they have the time, the skill, the knowledge, the expertise, or the bandwidth to do that. So you've got to have those two things. And the third one as a community health center is it fiscally sustainable? And that's analyzed by, are we bringing in enough revenue with this program to pay for the people that run the program? That's the first piece. That break-even piece is important. If it's a little less than break-even, We go back to 1 and 2 and say, okay, is this cost worth the health outcomes and the patient and staff satisfaction? If it's in the positive side where it generates revenue, then it's a no-brainer, but we have to make sure we're getting our health outcomes and keeping it satisfying. So
yes, I love what you said about keeping it satisfying for the patient and for the staff, because I think a lot of times in leadership positions, we just kind of silo ourselves and we make these decisions and then we kind of push them out. Maybe they are successful, but not as successful as they would have been if we would have gotten buy-in from everybody at every level. Does it make sense?
correct. So one of the things that we have done as an organization is we've got a strategic planning framework tool to monitor and manage what we're doing. And quarterly, we talk about, okay, what are our priorities for the next quarter? How do those priorities line up to our annual priority? And how does that line up to our 5 to 10 year priority? The executive team, the C-suite, will go and look at, okay, where are we at and what are the things we're thinking need to happen? And then after we've done that and brainstormed and had our meeting, the next day we bring in all of our senior leaders, it's a group of about 30 directors and senior managers across the organization, to say, here's what we're thinking. What do you guys think? Is this something that makes sense? Are you seeing, did we miss something? And then we work on collaboratively to come up with what are those actual priorities, and we cascade them down. So if I've got a major priority that I'm looking at, my direct reports have their own priorities that tie back, and they bring those things back. It's been successful for us to keep focus, because again, there's so many things out there. We used to talk about the shiny objects. Oh, that looks great. Let's go over there and pick that up. Oh, that looks good. Well, we didn't get quite to that one. We'll get there. Let's get that one next. How do you stay focused on the, for lack of a better term, the shiniest object until you've got it, accomplished it, managed it, and then you can move on to the next piece that you want to do?
So you mentioned this strategic tool. Can you talk more about that? I'm curious. Like, is it something you would be willing to share? Is it just a process you guys kind of have in your mind that maybe other health centers could benefit from?
It is not it's not proprietary. There is an organization called Rhythm. The tool is Rhythm. All of our staff that are engaged in using the platform, it's a web-based platform. There's a book to read about the process, the priorities, what they call a 13-week plan. So those are our quarters. You do a 4-quarter flyover where you look at the year. Because at the beginning of the year, we're talking about our annual priority. Okay, what does it look like each quarter? What were we thinking today in November for next year? What do we think it looks like each quarter to get to that annual priority? And then when we go back each quarter to our quarterly planning, we look back at what we thought that roadmap was going to be. Were we right? Were we wrong? Sometimes we're like, that is not where we ended up going. So let's move that and let's do new in that regards. It's a company that owns it. The owner of the company, Patrick Thean, had come virtually to our last strategic planning meeting for our group. He had met our CEO and they had a conversation, and he offered, time to our CEO, and he's like, well, I don't want time for me, I want time for my team. So let's have you come in and talk to the team about it. It's similar to, if anybody's heard of other things, 4 disciplines of execution, some of the other types of ideas of how do we strategize and how do we move things forward. It has a big strategy piece, but it also has an execution piece. We look at it weekly. We have to update our goals and our priorities weekly. Have we reached our goals? We have KPIs that are in there that we can track weekly or monthly. We have some clinical KPIs on cervical cancer, colon cancer, and breast cancer screening. Where are our rates? What's our target? What are we doing? And you make notes and follow. We like to joke that our CEO can be on the beach, and if he's got access to Wi-Fi and a phone or a computer, he can see what's going on with the organization and where we're at and how we're moving forward.
Yeah, I think that real-time piece is really important as well.
Yeah, absolutely.
So maybe we can talk a little bit about mission moments.
Sure.
So before our discussion, I was perusing your website, which I think is really amazing. It has so much great information on there. But one thing that I really liked was the patient stories.
Yes.
Is there one patient success story that really sticks out for you?
Thank you for that question. As you mentioned, our website, I did bring in copies of our 2023 annual report, which has a number of patient stories in there. That is also available digitally on our website. Our 2024 report is in process of being put together right now. I have been helping with the review to make sure that things are correct. Did they put stuff, we're like, okay, those headers are backwards. This header goes to these statistics and that header goes to those statistics. So doing some of that cleanup that we hope to have out and available by mid-September. But when we talk about patient stories, it's not one that's necessarily made it to the book because I haven't had a chance to talk to this patient. But we had a woman who was pregnant. It was her third pregnancy and she was high risk. She was advanced maternal age, which means she was over 35. She had diabetes and hypertension and needed to see the maternal fetal medicine specialist, if for nothing else then, are we doing things right? What's the plan to make sure she has a healthy baby? Because she was on our sliding fee discount. She didn't have insurance and she didn't have any way to pay for those things. And she knew that she needed to get the care, but she could not afford it. She couldn't afford to get ultrasounds as often as we would like. She couldn't afford the consultation fee with the specialist. And when her provider approached me and said, what can we do about this? And I said, well, let's talk to the specialist group and see if we can work out an arrangement on a discounted fee schedule, because she's on our slide, and that's what we do. We work with our colleagues in the community to try and help our patients that way. And then I said, we generate revenue from the 340B program to use for patients. That's what is part of the statute, is it has to go back to the patients, to the care and providing services for our patients. So we use those extra funds to help pay for her visits with the specialist and get the ultrasounds she needed and get the right care. And her pregnancy went to 39 weeks with a nice healthy baby, and everything went well with that. So when we talk about those things of what we do and why we do it, that's why the 340B revenue that we were generating in our previous arrangement was so important. It helped us build up and keep our dental program running when things were lean on dental. It helped us start that behavioral health program with the specialists and growing it to where it is today. We have probably almost 100 therapists that work for us or with us through different arrangements of employment and a contract with a company that provides our psychiatric services. That whole group is seeing anywhere from 650 to 700 patients a day. When we first were dabbling in this realm, we were seeing about 15. And through the hard work and dedication of their director, who had a vision, and we said, we like the vision, let's do it. That's what we've grown to, and we continue to grow. We've expanded a number of our locations to accommodate extra therapists, have the space for in-person therapy, and with the pandemic, that changed a little bit about how people get their care. And telebehavioral health is a huge piece of what we do. Some patients want to come into an office and see their therapist and talk to them. Some are okay not. Some would prefer not to leave the house. I want to stay home. I don't want to go out, right? We know about those things. So when we've added this space, we added 15 therapy spaces to one of our buildings. Well, we could have 30 therapists there. We could have 45 therapists there because they're doing some virtual and some on site. So we can share those rooms among the therapists to provide that, to get that 130 or 140 patients every week in to see somebody is huge. So that patient story I like to talk about when people are attacking the 340B program and trying to change how it looks from a legislative standpoint. I like to bring them that story to talk about what we do and how we do it. That's probably the biggest one for me.
I'm just imagining you guys like sitting around this big table sharing patient stories. I don't know if that happens or not, but I'm sure that stories are shared among the staff. How would you say that sharing of patient stories impacts the culture?
So we talk about the patients and the stories and what we have, absolutely. That's why we put them in our annual report, not because that annual report is not just for our outside partners, but it's for our inside staff as well, to recognize and see what we do, and an accomplishment book, if you will, for what we've done. We, every month, present a mission moment to our board of directors. We are a nonprofit organization as a federally qualified health center, so we have a board of directors made up of at least 51% community members. And every month at our meeting, we take a 5 to 10 minute block and bring in a mission moment. We have had patients come and talk for that mission moment. We have had providers come and relay what's going on. We have had some higher level where we gathered the information and just presented it to them because we couldn't get the people to be at the meeting. It steers and reminds everybody, this is why we're here. This is what we do. These are the tiny impacts you make. I've spent the last couple of months going out and meeting a little one-on-one with all the providers, all the medical providers in our organization, because we have about 80 or 85 of them. And that's been a little time to take a half hour, 45 minutes with each of them to talk about where they're at. And to a person, when I ask them why Adelante, they say the patients. The patients that are appreciative of the work that you do for them, the patients that are just glad to have somebody there. I had very recently spoke with one of our advanced practice providers who had been working private practice before they came to us. And what they told me was the patients in that private practice were demanding and not appreciative of or willing to take the information from the provider. They had read and they knew what they wanted, and this is what I want to do. Whereas in a community health center, we have patients that come in with that, but they're almost always willing to have the conversation. And you have other patients that they need the guidance, and they're appreciative when you give them the guidance and you help them to accomplish whatever that goal is.
It's much less transactional in that way. I think with a lot of fee-for-service models that we've, as a culture since the 70s, essentially have built this way of approaching healthcare, and we've, over the last, I want to say like 10 years, like convenience and like things on demand have become so prevalent that we see advertisements for our prescriptions. We see all these things that you're trying to be sold a specific thing. And so when that makes patients think they need that thing. And it sounds like you guys have much more of a collaboration with your patients.
We do. All the direct-to-patient consumer, direct-to-consumer advertising, as they call it, it gets information out there. And it's not always bad information, but it's in a 30-minute commercial where you can't have the context and the nuance of what it means and why do you need it. The drug companies want to make their money, so they're going to try and get people to ask for their medication for XYZ condition. But some people come in and say, I think I have this, I need this medicine. And then you go through, I said, well, let's go through the process. Let's test you. Let's review what you're doing. Why do you think you have this? Well, they said these are the symptoms, and I have those symptoms. Okay, well, but if I put those symptoms in my, medical organizer here, I can give you 17 diagnoses that have all those same symptoms as a constellation. So let's talk more about those symptoms and about what's going on to get them to a point where I really want this medicine. Okay, but you're doing really well on these medicines for that same condition, and you can afford these medicines. Mm-hmm. Changing you up to these others may or may not be the right way. We like to take that information that we have on medications and say, is this better, weighing the cost option, right? Because if you're getting the same result with a medicine that costs $5 a month versus $500 a month, take the $5 a month prescription, all things being equal. There are some pieces of that it's a balancing question, right? This one's $5, this one's $25. Okay, that's not too bad. But you still want to save some money, but this one that's $5 you have to take 3 times a day. And this one that's $25 you have to take once a day, which means you're more likely to take it every day and take all of the doses you need every day. So then there's some discussion there, and the patients have to make some of those decisions. Patients having a say in their health care is vital. It has changed over the years to patients coming in and waiting to be told what to do, to the next little iteration was patients coming in with a couple questions to understand the why, but still doing what the provider has suggested they do, to a group of patients of a certain age that are like, okay, I want to understand and I want to see, are there other options, and let's work collaboratively. And then we have patients that come in saying, I saw this on TikTok and I need this and I want it now, right? When we talk about cultural sensitivity and age-related competencies and these buzzwords that kind of go around, it's about being able to walk into each exam room and recognizing the person in that room has a perspective that's based on how they were raised, where they grew up, how old they are, and how do you talk to them and how do you communicate with them in a way that respects all of those pieces and helps them understand what you're telling them is, to the best of your knowledge, that's the right way to go and the best thing to do.
And taking that time, that's a hard balance.
The time is a hard balance. It definitely is. But with the integrated programs that we run, there's other people helping with that time. So if I'm in my office and I've got 3 patients that all have an appointment this hour and they all showed up at the same time, one of them has the top of the hour, one of them has the middle of the hour, one of them has the bottom of the hour, but they all showed up at the same time at the top of the hour. Great. We put them all in rooms. So now they're waiting. Well, I go in the first room. I can't be in the other 2 rooms. But we've looked at the patient's complaint and we've looked at it and said, well, they could use a behavioral health consultant today. They could use somebody to talk to them about why their meds haven't been improving, why their hemoglobin A1C and their diabetes doesn't seem to be moving the needle. Right? And then we have dietitians in our sites as well that can come in and talk to those patients and say, you know, what do you need from a dietary standpoint? Are you struggling? Do you need this? Do you just need, you're probably going to be on insulin today. Do you need me to go over that? It's the way that the providers move among the patients to help them get what they need. And by doing that, then they get more. So I don't have to be the expert on the behavioral health issue and motivational interviewing and all of those elements to get them to take better care of their health care. I have others that are helping with that. And that gives the patients a more well-rounded experience. And I could refer them out to a behaviorist to talk about these things and a dietitian, but then that's another trip somewhere. It's another day off work. It's another day getting childcare. It's 2 bus transfers and maybe the light rail. The patients that we take care of are a vulnerable population. We take care of everybody. We have non-vulnerable populations as well, if you will, because we do see everybody in our community. But the vulnerable patients really have hard times. If we can give them everything they need at their one visit, then it just makes sense to do that. It does lead to better health outcomes and does lead to where we're at. I always say that you can't be healthy in your community if your community isn't healthy. There's another visual I like to talk about where, you know, our roots as Adelante started with our migrant farm worker community, right? Going out to the farms and providing some health care to the patients on the farms. Great. Well, if we go out to a farm with 200 farm hands on it and we get them to be the healthiest, most ready and able to work farm hands in that farm, and nobody takes care of the owner of the farm, and they don't get their regular screening and they die early from a cancer or some other issue, now there's no farm. Yeah. And I have 200 healthy people to work and nowhere for them to work. So it can't be this narrowed approach to what we do. Everybody in our community has to be healthy to whatever degree they choose to have that be. We're there to make sure they have an option to do that. You have to take an asynchronous, nonlinear approach to providing that care because people don't have an hour and a half necessarily to wait, but they could do 40 minutes. And if 10 minutes are with the behaviorist and 10 minutes are with the dietitian and then 20 minutes are with the provider and they're out of there in less than an hour, that's better. As opposed to, okay, now I need to wait for this person. I'm going to sit in a room. Now I need to wait for this person. Next thing you know, their day becomes 2.5 hours at the doctor's office. That doesn't work. You have to be able, as a healthcare provider in an integrated model, share that care among those integrated team members. We talk about our model having the patient and the medical provider, the physician, the nurse practitioner, the PA, in the center of that model. And we have all these services that wrap around that, them in the center. It's patient-centered. The patient doesn't have all the medical knowledge, so you need the medical knowledge person in there as well to help coordinate what they need. But we also do social determinants of health. Health-related social needs is the new phrase for that. Screening on all our patients. National survey from our National Association of Community Health Centers has been vetted and tested and validated to help us identify where are people struggling, because they don't always tell us. Sometimes they don't think it's a struggle until you ask them the question, because they think it's okay that every month they switch to another buddy's house and sleep on the couch. Okay, that's technically unhoused. So how do we help with that? Where are the struggles? Where are the barriers? And having that opportunity to ask the questions and get some of those answers plays to their health care. If we find out they're homeless and they weren't telling us, they don't have a refrigerator for their insulin. So how do we help them be healthy with the means that they have? And how do we get them hooked up with services to support what they need?
I love the team approach. I want to be cared for like that.
We're tweaking it, we're playing with it, we're making it work. But when we first rolled it out in a test environment, we asked the patients. We surveyed them. We told them we're going to be doing something new. It's going to be a little different than what you're used to. And almost all the comments were positive, and a lot of them were like, I felt like I was listened to. I felt like all my questions were answered. I felt like I had a group of people that really cared about me, as opposed to just processing them through the turnstile.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.